Hello, 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 hello. Good morning, respected teachers. The topic for today's JC presentation is unconventional pontics in fixed partial dentures. Introduction. Clinical success of a fixed prosthesis depends upon the type of pontic design. The pontic must fulfill the following roles: replacing the functions of the lost tooth, aesthetics, adequate oral hygiene, and preventing tissue irritation. In addition, the pontic must meet certain structural requirements to ensure the mechanical stability of the restoration. Main components of a fixed partial denture is also a pontic. The word pontic is derived from Latin word pons, which means to bridge. So the pontic forms a bridge between the abutment teeth. Coming to the definition of a pontic, an artificial tooth on a fixed partial denture that replaces a missing natural tooth, restores its function, and usually restores the space previously occupied by the clinical crown. William Howard and Clarence Pruitt in 1982 gave the standards of pontic designs, which stated that firstly, the tissue surface of the pontic should be convex for ease of cleaning. Pontics should never have positive pressure on the underlying tissue. Pontics and connectors must be of adequate build to withstand occlusal forces, and pontics should restore the aesthetics. The commonly used pontics in fixed prosthodontics are ridge lap pontic, modified ridge lap pontic, ovate pontic, conical pontic, and sanitary pontic. So in today's article, we will discuss some unconventional and modified types of pontic designs. Firstly is the modified ovate pontic. It was proposed by Liu in 2003. It involves moving the height of contour at the tissue surface from the center of the base to a more labial position. So we can see in the diagram, in the ovate pontic, the height of contour is above the ridge and in the center of the place, but in the modified ovate pontic, it is shifted more labially. So shifting more labially, therefore, it does not require much facial lingual thickness to create an emergence profile, and it is easier to clean as compared to other pontics. The height of contour at the tissue surface of the pontic is 1 to 1.5 mm apical and palatal to the labial surface. So apically inside the socket 1 to 1.5 mm and also labially from the socket. Little or no need for surgical augmentation of the ridge is required. If it is a freshly extracted socket, there is no need for surgical intervention. And it has a more effective air seal, and dental floss can be brought into intimate contact with the tissue contacting surface. A disadvantage of the modified ovate pontic is it may leave a shadow in the apical area of the tooth at the gingival margin if a high smile line is present. According to Chun Lin Steve, the following advantages may be observed when using a modified ovate pontic. Firstly, it has excellent aesthetics as it corrects the emergence profile of the patient. It is fully functional as it satisfies all the functional requirements of the prosthesis. It has greater ease of cleaning. It forms an effective air seal which eliminates the air or saliva leakage. The appearance of a free gingival margin and the interdental papilla is there. There is elimination or minimization of the black triangle between the teeth. There is little or no ridge augmentation required before the final prosthesis. The next design is a modified sanitary pontic or a arc fixed partial denture or a peril pontic. It was given by Jan in 1983. It is mainly used for lower posterior missing teeth. The pontic and the connector design reproduces the anatomic contours. It is very easy to clean and the gingival portion is shaped in an archway between the retainers. So we can see here in the figure, the two retainers are present and an archway is made between the two retainers. It is less susceptible to tissue proliferation that can occur when a pontic is too close to residual ridge. So the indications for the arch fixed partial denture are extreme resorption of alveolar ridges, shallow vestibular trough, insufficient or lack of attached gingiva, previous periodontal treatment or surgery, high muscle or frenulum attachments. The next is the occlusal bar. The occlusal bar does not contact the edentulous ridge at any point. It is mainly used when the edentulous space is small mesiodistally and large occlusocervically, or both the conditions are present. But the disadvantage here is it permits large pieces of food to lodge in the spaces between the pontic and the soft tissues, and this fact can be annoying to the patient. Next is the stain pontic. It is a variation of a modified ridge lap pontic, and it is specially designed for sharp edentulous ridges. So whenever a sharp edentulous knife edge ridge is present, this is a form of modified ridge lap pontic which is given. It has minimal tissue contact and it has acceptable aesthetics. It has a contraindication, that is, it is not used in edentulous ridges with broad buccolingual dimensions. Because if broad buccolingual dimensions are present, the contact will be increased. The next type of pontic is spheroidal pontic. So spheroidal so called because it is spheroid in shape. The pontic contacts the ridge without any pressure. Only the tip of the pontic contacts the ridge on the ridge or on the buccal side. The next is the hollow pontic. So hollow pontics have an advantage that they reduce the metal based ceramic pontics, and so the metal part is reduced in the pontic, so therefore less porosity is present in the metal. It is easier to solder when necessary, and because it has lesser amount of large heat sinks. So here is a wax pattern of the hollow pontic. So they have the potential improvement in strength due to sandwich of porcelain and metal which is formed in the whole hollow part. It presents high resistance to tensile force. So the technique which is followed here is carving a solid pontic in wax and then hollowing the center of the wax pontic from the underneath. So this way a hollow pontic is created. The porcelain application involves filling the hollow center with porcelain and firing for 2 or more cycles. The next is the Inzoma pontic. It was given by Mellon and Koth. So what technique is followed here is horizontal ridges are added to the pontics, so to the abutments. So in the posterior Inzoma pontic, the buccal and the lingual ridges were added to the abutment for porcelain support. So as we can see here, the buccal and lingual ridges were added with horizontal ridges so that it can support the pontics. And in the anterior Inzoma pontic, the labial horizontal ridges are added. So only labial ridges are added in case of anteriors. The next is a split pontic. So here the attachment is placed entirely within the pontic, and it is used in cases of tilted abutments. The wax pattern is formed for the anterior 3 unit, and then the distal arm is attached to the pier abutment. So as we can see here, this is the mesial side or the first 3 unit of the prosthesis. It is formed first and then the distal side is fabricated. So first the burnout and the casting of the mesial half is finished and it is seated on the cast, and then the distal side is waxed. If the distal retainer has a wing, it is cemented first and then the retainer pontic segment mesially is seated. Coming to the review of literature, the first article is on the Phoenix pontic, a review article. So this article mainly describes ovate pontics and modified ovate pontics. So the word phoenix is used because phoenix represents transformation and renewal. So ovate pontic here transform and renews the original tooth as it resembles a natural tooth because it emerges from the natural tissue profile and it preserves the tissue profile. So it renews the natural tooth. That's why phoenix word has been used. So ovate pontic is the most aesthetic pontic, and some modification and changes can be done to it to preserve the extraction site. So first is the socket preservation technique. Here immediately after the extraction, tooth preparation of the abutments is done and provisionals are given for 3 to 4 weeks. So as we can see here, extraction has been done in this socket and immediately a provisional has been given with the modified ovate pontic, so that preserve the tissue contours and the emergence profile, and it is retained for 3 to 4 weeks. The next technique is the soft tissue residual ridge augmentation. So augmentation is done in cases where the pontic site is edentulous for a long time. So firstly, gingivoplasty and alveoloplasty is done using a torpedo burr under anesthesia. Then the preparation of the abutments is done, and then a provisional extending 2 to 3 mm inside the pontic side is given to preserve the socket, and then it is replaced in 3 to 4 weeks. So as we can see here in the picture, a torpedo burr is used for gingivoplasty and alveoloplasty of the ridge. And then a provisional restoration is given for 3 to 4 weeks. The next technique is soft tissue residual augmentation using lasers. So it is a similar technique with, of the ridge augmentation, but the only difference here is the armamentarium used is soft and hard tissue laser instead of the burrs. So lasers are used for the augmentation of and gingivoplasty of the ridge. The next article is modified ovate pontic for immediate anterior tooth replacement. So they have given a technique for placing the modified ovate pontics immediately after extraction of the tooth to preserve the soft and hard tissue for enhancing aesthetics. So this is the intraoral view of the site, which has 2-1 as the root stump, and 1-1 and 2-1 are to be 1-1 and 2-2 are to be used as abutment teeth. So firstly, a diagnostic wax up is done, and then preparation of the abutment teeth, that is 1-1 and 2-1 has been done. Then preparation of the future extraction site to receive an ovate pontic of the cast is been done. Then on this cast, a heat cure acrylic provisional restoration with modified ovate pontic is prepared. Then the extraction of the 2-1 root was done with the help of microtome to preserve the buccal and lingual plates and interdental papilla. So a very atraumatic technique of extraction is to be followed. And after the hemostasis and clot formation has been done, modified ovate pontic was adjusted to be 3 to 4 mm inside the socket to support the bone and soft tissue contour. As it is a modified ovate pontic, it was placed more labially on the ridge than the ovate pontic. So this is an image of the immediate provisional restoration. After the third week, crown lengthening was carried out to achieve proper height of contour and proportion of the gingival contours for aesthetic. So this is an image of a 3-week post-extraction. The tissue condition both at the abutment teeth and the pontic were monitored for 1 week, 1 month and 3 months. So this is the image after 3 months of post extraction. So we can see here the socket is still preserved, and the abutment here will give an emergence of a natural tooth. So final tooth preparation and final impression were made to receive the full crown coverage metal ceramic restoration after a time interval of 3 months. Control physiologic pressure was used at the pontic site to enhance the interdental papilla, thus creating a natural looking effect. So this is the intaglio surface of the final restoration, showing a modified ovate pontic. And this is the final metal ceramic restoration. Coming to the conclusion, what you focus determines what you miss. A missing tooth is always a center of focus, as the integrity of the stomatognathing system depends on the replacement of this tooth. The guidelines laid down should be followed to obtain a successful fixed partial denture. The selection of a pontic should be done only after evaluation of the pontic space, the retainers and the abutments to be used, aesthetics, ridge condition and contour, oral hygiene of the patient and occlusal of the patient. These are my references. Thank you.